Dr. Wallace, thank you for your invitation, and good afternoon. This is really a great privilege and honor to be invited here to share some of our health disparity research with Asian American communities. And as we know, Asian Americans has a dramatic increase in terms of its demographic. I'm trying to move forward on this one.
The arrow to the right.
That's what I did. Doesn't, sorry.
You just need to press it.
Then press it hard. Okay,
yeah,
sure.
Twice.
Press it twice. And, you know, there is, in general public, there's a misperception of Asian Americans as a model minority. And I wanted to take a further look at about this demographic and also the minority populations. Asian is one of the fastest growing population in the United States. There are about 13 million, 5% in the US. It is estimated that about 20 million by 2020. So this will be around 8% of the US population. And this is also the second largest foreign-born group, which also have many of them coming from China, India, Korea, Philippines, as well as Vietnam. There is a great deal of culture and language differences. This is the most diverse population. There are about over 100 Asian languages and dialects that are spoken in the US by this Asian population. And the majority of them speak another Asian language at home besides English, and which has really given a lot of indications about how we deliver a healthcare system. And with this population's geographic distribution, majority of them live or reside in West or East Coast, and especially in the large cities of San Diego, New York City, LA, Houston, and Philadelphia. In terms of age group of this population, and it is relatively younger than the general population, and also education-wise, oops, trying to going back.
The up arrow.
Up arrow. Okay, here we go. In education, it is really also have quite a bit of diversity in the different Asian groups. The education level are very different. The Southeast Asians have the highest high school dropout rates. And in terms of college education, Vietnamese is about 15%. And if you go to other Southeast Asians, it's about 5%. And in terms of income and poverty level, this population also, some groups has a higher poverty level than the general population. One of the areas that we have been focusing on for many years is look at cancer health disparities among the Asian American populations. And especially on certain cancers that are a lot more experienced in this population. Let's see, trying to get back. Maybe I'm not pressing hard enough. Stuck there. Anyhow. It doesn't work. Okay.
Okay.
Can we go back?
Back more?
Yeah, back. Further.
This one?
No, the previous one. Yeah, okay. And the Asian population has experienced the third highest incidence rates of breast cancer, colorectal cancer, as well as lung cancer. And this population also experienced the highest incidence and mortality rates of liver cancer as well as stomach cancer. And there are certain high high prevalence of hepatitis B related liver cancer. So this disease are not, especially liver and stomach cancers, viral related, is not very much higher in other general population. And this incidence has reflected in this data. And in terms of cervical cancer, Vietnamese women have 5 times higher incidence and mortality rates, and Koreans also twice incidence rates among the general population. Somehow this doesn't work.
So sorry, I can.
Maybe the file is too big. Okay, here we go. And look at further regarding some groups in the Asian population also experience diverse rates. And with Japanese as well as Koreans and South Asians and Chinese, they have much higher breast cancer incidence rates than other groups. In terms of lung cancer,
Just try and move it. I apologize.
yeah. There's no mouse here. Can you move back? Yeah.
This one?
Go back. Yeah, one more. Well, I will skip that. For lung cancer rates, actually, it is higher than all Asian groups, especially among Vietnamese, Koreans, Filipinos, and Chinese. That is very much smoking related. And as we know, oftentimes if you look at the national data, and the smoking rates is not very high, there is actually some issues related to the national data collection, because most of the time these national studies reach English-speaking Asian populations, so the non-English-speaking Asians actually have much higher smoking rates. This is one of our recent studies trying to look at the early detection in different type of cancers among various Asian ethnic populations, and also health checkup, and especially among Chinese, Korean, Vietnamese, and the Cambodian population. And if we take a look at just on these few cancer early detection, and you can see even among the Korean population, about 65% or 55% of them have not had health checkup over 5 years, had 5 years ago or never had. And if you take a look at further of breast cancer, cervical cancer, the never screening rate or 5 years ago have done screening is also very high. There is a variation among various groups. If you look at colorectal cancer, the never screening rate is high among all of these groups. So this gives us a sort of a baseline of where we take in terms of cancer detection. Thank you. All right, you can move on. Next one. And Asian populations, they also experience a large different type of barriers which has prevented them from health care services or access healthcare services, especially related to the issues new immigrant population. The targeted population we deal with, 90% of them are new immigrants, specifically primarily in the East Coast area, Washington, D.C., Delaware, Pennsylvania, New Jersey, and New York City. So these populations have specific characteristics that we have to deal with. And the other barriers related to unfamiliarity of a healthcare system, and the healthcare system oftentimes is not prepared to deal with these populations because of language issues, because of culture differences, and other related barrier. And the issues related to language, oftentimes we see the patients or the participants we work with have high English, limited English proficiency, and transportation is also an issue, lack of health insurance, and distrust with the mainstream health system. And the other part is the not fully understand what their rights are as well as their benefits. So this is really give us a good opportunity oftentimes to provide intervention for the population and also help them overcome the different barriers. With this information in mind, we have responded this needs in the Asian population. Can I have the next slide? Okay. Yeah, all right. This study really indicates the Asian populations has experienced the highest difficulty in communicating with healthcare providers, especially coordination of care in cancer and other health disease. Okay. In response to the needs of our Asian community, and we have taken action in a number of areas. In 2000, we have received funding from NIH and established the Adhikar Special Population Network. This is a regional network that focuses on different, not only on the smoking, but also on various cancer issues. In the same year, we established the first Asian Community Cancer Coalition. In 2000, we need to go back, it's too fast. No. No, we need to go back. You went too far. No, you got too far. You need to go back.
Here, just tell me to stop.
No, you went all the way. This is done. Oh boy.
Which one is it?
Keep going.
Okay.
Keep going. Next one. Okay, keep going. Sorry about this technical.
No, it's
yeah,
not
here
right.
no, the previous one. Yeah, here we go. Can we get larger, or that's pretty much, maybe we just, yeah, maybe just stay this way, so just okay now. Okay. In 2003, we have expanded the Center for Asian Health to the New York site, as well as to 2 sites in China. And 2005, we established, continuing expanding the regional network of Asian Community Cancer Network. This network is consisting of over 65 community-based participatory organizations, 35 healthcare providers, and many research institution collaborators. This is NIH NCI funded. In last 2 years, we received the R01, 2 R01s focusing on large randomized trials of cervical cancer in Asian American communities throughout the region. And also in last September, we received the R01 to conduct a randomized trial on hepatitis B related liver cancer intervention in Asian American communities. So these are sort of a few milestones. I would like to be more specific about the issues, how we have responded to the community needs. This machine just doesn't like me. Okay, next one. Oh, we can look at this index.
Hi. Thank you, I'm sorry. It's having difficulty moving back and forth.
This is the one we're going to look at.
This is okay.
Yeah. No, yeah. This is the next one, yeah.
Oh, I'm so sorry. I just came running from Millbank.
So the targeted population that we have been working with primarily the Chinese, Vietnamese, Cambodian, and Korean underserved and other underserved Asian Americans. Keep going. I've done that. Okay, that's next one. Yes, perfect. So
okay.
is it
Up and down.
Up and down. Okay.
Perfect.
Okay. The targeted population we have focused on are Chinese population, Korean, and the Vietnamese and the Cambodian, as well as other underserved Asian populations such as Hmong, Laotian, and also Asian Indian populations. And we have a team of multilingual staff who have been in different area of the region. And this is our network geographically in the Asian Community Cancer Network in Washington, D.C., Pennsylvania, New Jersey, and New York City. We do have a New York office in Manhattan, which has been primarily serving the Chinese and the Korean population. This is our headquarters in Philadelphia. And here I mentioned about our work also has expanded to in China. We have 2 sites. Currently we focused on an intervention in smoking as well as breast cancer. This is still not working.
Oh, press the down.
That's what I'm doing.
The up.
Up.
Mm-hmm.
It's not working. Oops. Okay, here we go. Huh?
It's just going to take a little longer.
It takes longer, maybe it's large slides, yeah. So the major approach that we're taking is to reduce cancer health disparities through education, research, training, early detection, and care and survivorship. So all of our programs are incorporating all various components. I think Dr. DeClemente's talk really has laid a very sound groundwork and a framework of what we're doing. And I think education is very important, and sometimes you provide the knowledge doesn't mean you're going to change their behavior. So we do research to trying to test various culturally tailored interventions to see how this can be more effective for the Chinese, Koreans, Vietnamese, or Cambodian. Each population has its own unique culture and characteristics. So it is a continuum of our intervention. These are the sort of the major 3 domains or 3 departments we have at our center. And we have a strong focus in cancer, primarily in cervical cancer, breast cancer, colorectal, hepatitis B-related liver cancer, lung cancer, as well as prostate cancer. The other areas that we have focused on is chronic disease of hypertension, diabetes, and heart disease, as well as osteoporosis. The third focus of our center is on tobacco. I'd like to elaborate a little bit more of how we have done in these programs. For example, in the breast cancer program, oftentimes we take the first step of reaching the community and partnering with the community leaders and various partners. But the most important part, we are trying to use and adapt and also incorporate culture considerations into the intervention program, trying to change their knowledge as well as beliefs and attitudes. And we also trying to use ecological model to change the system, or to provide facilitators and to help participants have better access to the healthcare services. So not only we provide education, but also provide navigation and to help participants overcome the barriers in the healthcare system. So the outcome of most of these studies are increasing the early intervention, early detection of breast cancer, cervical cancer, colorectal cancer, hepatitis B, and all these are going through a continuum from education to patient navigation, as well as helping them in the coping process if they are identified as abnormal cases. This is enormous effort, oftentimes collaborating with healthcare partners as well as community organizations. And some of our programs have already demonstrated promising results, especially as Dr. DiClemente mentioned, oftentimes when you adapt and include culture factors, you will also increase the effectiveness at the individual level as well as the program level. So these are sort of our major effort in the continuum. And so is with the smoking cessation. With the smoking cessation program, we have been trying to tailor toward individual as well as at the organizational level. And oftentimes we have to set up very appropriate and realistic goals, whether cessation is the only the aim and or quit attempts. So we use various outcome variables for these different programs. These are just some of examples of our outreach and a program in the community. When we started our initial programs, these are sort of the first step. And also we provide individual interventions and education in the community as a group smoking cessation at individual level for smoking cessation. Each of these programs are delivered in the Asian languages as well as tailored toward individuals' needs at different stages. So these are the Chinese, Korean, Vietnamese smoking cessation program. These are some of the examples of our, I'm trying to go back. These are examples of our cancer education program in the Chinese, Korean, Vietnamese, Cambodian communities in the Philadelphia as well as New York City and in the region. So we provide these education in partnership with the community organizations and also in providing training not only for the participants but also for the community partners. Okay, that's the previous one. All right. This is an example of our patient navigation, where, as I mentioned, the healthcare system, it is not ready to really serve the Asian population. Oftentimes, the translation line is not really very effective, so person-to-person navigation is very critical to overcome the barriers, to provide clinical support, and this become one of the critical component in our intervention, and oftentimes this will increase the effectiveness of the program. This is an example of our patient navigator who is helping the patients conducting the mammogram, and also if there's abnormal cases, our navigators also help them getting further evaluation, further diagnostic testing, as well as follow-up treatment. So these are the components we'll look at not only at the individual level, but also at the system level, family support. So it's a lot more as an ecological approach to incorporate into all these interventions. I wanted to sort of share some of these programs that have demonstrated some promising outcome. For example, our cervical cancer program in the Vietnamese and the Korean population has already demonstrated effective outcome. In the intervention program, we have observed the screening rates from baseline 32% to 98%. And also we have observed the hepatitis B program intervention and also the outcome from intervention group. We observed a baseline screening at 12% to the 6 months follow-up of 88%. Our smoking intervention quit program trial have also demonstrated various outcomes in terms of smoking quit rates, about 40 to 60%. So these are sort of examples of some of our intervention that has been going on over the past years. In terms of the future directions, as I mentioned, I think a continuum of intervention is very important. Oftentimes we've seen their health fairs, their outreach activities. Sustainability is very important, and especially at the time when resources are very limited. And I think long-term commitment at all levels, individual, community, and also the scientific community and healthcare providers, it is essential for the success of serving this population. And I would like to also thank our network who have made contribution to the success of all these programs, as well as the contribution to the health of Asian communities. So I would like to sort of open up for some questions, and sorry about the technical difficulties.
Yeah, we apologize. That's our issue. Sorry about that. Thank you for bearing with us.
Sure.
Okay, so they could actually switch the keyboard.
Yeah, that's what they're going to do.
Okay, so are there any questions for Dr. Ma? Observations? Comments? Dr. Johnson?
Thank you, Dr. Ma, for your presentation. It was very informative. I just want to beg your pardon and ask for your forgiveness in advance if I sound ignorant in phrasing some of these questions.
Sure.
First off, I am acutely aware of the fact that we see Asians, for the most part, as the model minority.
Yes.
The expectation is on most of our lines of thinking or thought is that they're highly educated. Being highly educated, that means that their socioeconomic status is somewhat higher. The expectation is that if their socioeconomic status is somewhat higher, then therefore their health status is going to be commensurate with that. It's just amazing to hear the staggering statistics that you just quoted. Once again, I'm going to apologize and say, as you were giving your talk and you were talking about New York, Philadelphia, mostly urban centers, I saw so many parallels and the kinds of things that we're seeing in our own communities of African, Black, African American, and what have you. My question has to do primarily with racism. How much of what you're experiencing in your Asian community do you feel may have its origin or its root in what we see as institutionalized racism here in these communities that you're talking about here?
Well, that's a very good question. I think every group has prejudice. Every group has prejudice, and oftentimes you think about, we lump all Asians together, and actually each community is quite congregated and isolated. Chinese oftentimes do not work well with the Koreans, nor with Vietnamese, but oftentimes I think these are the barriers, we're the victim of our own culture. And racism does exist, even we don't use that term or the language, and so is prejudice. And we often look at people who don't have insurance, and who people have insurance who are in this higher socioeconomic status and lower socioeconomic status. Definitely they're, in terms of health care, are not the same, and also the quality of care not the same. And oftentimes we see people who do not have health insurance, even they come to the ethnic communities, clinics, and who have the ethnic physicians. If you do not have health insurance, you are not going to be treated the same way. And oftentimes you have to have your cash on the table before you are able even to be consulted. So I think your question is really very valid, and I do believe there are prejudice even among within the group, and of course across ethnic populations, oftentimes also existing, and that also play a role in the healthcare system. Yeah.
Well, the reason why I asked that question has mostly to do with the fact that as you see your population increasing,
right,
that's going to happen over time. What, if anything, can other minority groups who may happen to reside in the same communities that you're talking about, I'm speaking specifically of the urban centers,
right,
that we may be able to do to be able to affect the kinds of change that you would like to see occur in the Asian population?
Yes, I wanted to really use that as a you mentioned as a very good example. Oftentimes we look at the model program that has been very successful in the African American community as well as Latino. So, for example, the Asian Community Cancer Network, we started in 2000, and but these programs has already existing in the African American community. As you recall, National Leadership Program that is started back in early 90s, and the National Latino Program has started in 1950s. So we actually coming in as a much later time. But the awareness level and the program development, we learned a lot from the programs that has already demonstrated success. Of course, each community has its own unique characteristics, so we adapt and we learn. And also, oftentimes in our community advisory board, not only we have Asian community leaders, we also invite African Americans as well as Latino community leaders. I think there's a lot of things we could share and learn from one another. Yeah, that's a very good point.
Are there other questions?
Right here.
Great.
Hi, Dr. Ma. Thank you for a very informative presentation.
Thank you.
I was wondering about a similar question, which is wondering about whether your research looks at the role of stress and coping on some of the health outcomes, and in particular, interested in the impact of acculturative stress, especially given that much of your population, 90%, are immigrants, and even those who've been here for a long time are still dealing with acculturative stress. So that's my first question. And then the second question has to do with an issue that both you and Dr. DiClemente raised, which is that the statement was that we know that making cultural adaptations to interventions results in improved, well, we know for sure it results in improved engagement and retention, but possibly impacting outcomes. And I wonder if you have any data to support that, because that's often a claim that is challenged in the field, which is that cultural adaptations don't necessarily lead to improved outcomes.
Right. Well, I wanted to answer your second question first. In terms of culture adaptation, I think Dr. DiClemente has put out a very nice framework, and oftentimes, even the culture change, even there's culture issues, and that you do enough of needs assessment, focus group, you get enough input from the community. As time goes by, the culture does change. I think how that could tailor toward not only at the group level, but also at the individual level. For example, and when we doing smoking cessation among the Koreans, the culture is very different from what we do with the Chinese. And sometimes because of the male macho mentality, they do not want their wife to know they've already thinking about quitting, because smoking is associated with the adulthood and manhood. So these are the things that oftentimes, as Dr. DiClemente mentioned, we do ask our clients and also the smokers and coming in to see if these are the culture issues that they would feel is effective as a sort of a consumer. And this is the part that we have been keep on changing and testing. And oftentimes we do use the measurements and variables have been already proved validated in other ethnic groups. When we bring it to the Asian populations, the question doesn't mean anything to them. So we have to change the questions in the sort of the culture context in the situation, the culture that they're familiar with. For example, when we talked about the cost of smoking, and we would not use examples about the tax, or we have to talk about if you do not smoke, you can save a ticket for go to Korea or go to China. So you put in the context that they can relate and they can associate with. And in terms of whether we have any data to support, I think we do have some intervention publications already demonstrated the outcome effectiveness, and which we're trying to look at the variables at not only at the knowledge level, but also belief, attitudes, and behavior changes at the different stages. And not only at the post-test, but also 3 months, 6 months, and 12 months. And these are sort of giving us some promising impact, but the culture adaptation, as I mentioned, each time and each study, and we have to sort of continue to modify to tailor toward the population we work with. And in the sense that we're trying to use the evidence-based intervention, not only tested in other population, but also tested in our population. For example, those R1s we got that I received from NIH, we have adapted the health belief model, social cognitive model, but a lot of times these measurements already changed its way of how to ask patients, and the intervention contents have changed. However, the framework is there, the major principles are still there. So that's how we do the adaptation. And so it's still very challenging, and it takes time to really prove it works for the population. And I'm sure we have a long way to go. And I really see this as a beginning of our journey in working with the Asian population. This is such a new area, has not been focused on at a different level. Yeah.
Okay. Excellent. If we could do another question in 2 minutes, 2.5 minutes, or should we? Yes, come on.
Hi, Dr. Ma. Thank you for your presentation. I have a general question where you cited that you really focus on the 90% on the most recent immigrants.
Mm-hmm.
And I'm particularly curious about the different generations, looking back specifically for the Chinese American communities that have been here and have a longer history, back 5 generations, 6
right.
generations, going down to Louisiana for Filipino Americans.
Sure.
And really looking at the health implications as you go along for those generations. Have there been any studies? Are there any plans for your center to really look at that and just try and chart out and map that sort of pattern and incorporating the other woman's question about acculturation and how it's different?
I think that's a very good question. We have done some baseline studies trying to look at the smoking behaviors and the cancer early detection behaviors, how the acculturation factors would impact on these behaviors. But in terms of intervention, we have not focused on that, because one of the reasons is we're looking at majority of the Asian populations are foreign-born, and especially when you look at ethnic minority health disparities, and these are the issues often occur among the most underserved and also uninsured, low income, as well as the people who have limited English proficiency. However, I think your question is very valid because in terms of this community, we do need to look at this, the diversity and the variations among different generations and groups. And we have not particularly looked at English-speaking Chinese or people who have been here for several generations. And oftentimes, this could be another stereotype when we look at the demographics and people who have been here longer or who have higher education, they're more likely to have insurance and have better resources to seek health care. But not necessarily among people who have been living here for 40, 50 years, but they have always lived in Chinatown. They're always lived in their own communities. So even the acculturation has been, very different among people who live in the mainstream and also those who just live in their isolated communities. That is a very interesting area we should look at. Thank you.
Okay, well, let's give Dr. Ma a hand.
Thank you.
We're so grateful for you sharing your work. And what you shared is really the ideal kind of model where a researcher is not only doing work regionally, but nationally, as well as globally, internationally. So now we have Dr. Herbert Freudenberg. Nick.
The preceding program was brought to you by Teachers College, Columbia University. Please visit us online at itunes.tc.columbia.edu.